So, nephrology, girl with urine culture positive for E. coli. She is on anti-psoriasis treatment. Referred from family physician for treatment. You repeat urine analysis and it was normal. What will you give her? Now, a girl is known to have urine culture positive for E. coli. She's known for that. That means past history. And also she is on anti-psoriasis treatment. Referred from family physician. You repeat urine analysis and it was normal. What will you give her? You will give her prophylaxis with nitrofurantoin prophylaxis. Is there anything here related to anti-psoriasis treatment?
But why is she given prophylaxis? Why is she not treated for the positive blood culture, urine culture? I'm assuming urinalysis is urine dip. So positive culture for E. coli means it has to be treated first before the prophylaxis. And
I
is
think
this the first?
this is what I think is this is past history, I think. Previously, I think she was positive with E. coli, but now they repeated the urine sample. This was normal, but still they will give her the nitrofurantoin and wait for the culture, maybe. This is what I think, because now if she is positive for E. coli, they should treat her with medications, right?
Yes, it should be treated.
Yeah, it depends. We don't know. The questions here might be they have intermixed because this is written by someone. But one thing we have to remember that if the child is treated and already cleared from infection and she's on anti-psoriatic treatment, better to keep her on prophylaxis. Maybe because they use immunocompromised drugs, right? This is the reason for to keep the nitrofurantoin prophylaxis. Next is the neonate with oliguria, hematuria, and high blood pressure. Full flank mass, creatinine 240 and urea 16. What you give? Hydration, dialysis, furosemide, dopamine. First thing you give is the hydration because they are suspecting renal vein thrombosis here. So there is a neonate who has less urine, hematuria, high blood pressure, flank fullness, and also the I think the picture of acute renal failure because of the renal vein thrombosis, and urea is 16. What we give is we give hydration. Next is the full-term baby, insignificant perinatal history. Gross hematuria, unilateral flank mass, again, heart rate 110, RR 45, WBC 7000, platelets 2 lakhs, hemoglobin 7, creatinine 2, urea increased. Diagnosis, again he is showing the same picture for us. Full-term baby with no, I think the perinatal his course was normal, but now presents with gross hematuria, unilateral flank full mass, and heart rate is 110, respiratory rate is 45, platelets 2 lakhs, WBC 7000, creatinine 2. There is raise in urea, means again there are features of renal failure. He's telling the cause here is renal vein thrombosis. So even there is renal failure, you will check, you will take the cause, which is the cause for this renal vein thrombosis. Child on steroid, this is his known case of nephrotic syndrome, came with severe bilateral flank pain. What do? We do investigation. At the same time, he's telling WBCs is 22,000. Neutrophils are raised. That means going on with the picture of some bacterial infection, if at all there is infection, if at all. Urine WBC to RBC, there is hematuria. RBC is 1,500. It's raised. So he's on steroid with nephrotic syndrome, but now presenting with severe bilateral flank pain and high WBCs and high neutrophils with urine RBC 1,500. Best investigation will be Doppler ultrasound. Rectal and supine X-ray, CT abdomen, and IV pyelogram are the options, but the best investigation is Doppler ultrasound because renal thrombosis is one of the complication of nephrotic syndrome. Renal vein thrombosis is one of the complication of nephrotic syndrome. We all know because nephrotic syndrome. What is the reason for nephrotic syndrome having thrombosis?
So I put complementemia. There's loss of complement 3, and then also loss of fluid, like hypoproteinemia also.
Yes.
Dehydration also.
Yeah, that will make the blood not very flowy, thick like this because of the less proteins. So renal thrombosis is one of the complication of nephrotic syndrome. Some children develop acute complete venous occlusions, which is characterized clinically by sudden onset of macroscopic hematuria, flank pain and or tenderness, and in children with bilateral disease, acute renal failure. If there is bilateral affected, there will be acute renal failure, and there will be complete venous occlusion and macroscopic hematuria, flank pain, tenderness. These three symptoms are very important here. We have to remember for renal vein thrombosis: macroscopic hematuria, flank pain, and tenderness. And one more important thing is if it develops bilateral, the renal failure, acute renal failure becomes common. But maybe unilateral, the other kidney will be working well, so you might not see the complete features of acute renal failure. In such cases, Doppler ultrasonography shows an increase in the kidney size and the absence of blood flow in renal vein. This information he has given to you from Up to Date. And the second option for you is CT with contrast. So let's again go, because there is this question on renal vein thrombosis is common on exam. So steroid, whenever you see the steroid dependent nephrotic syndrome, usually they are more prone for thrombosis. So they might also present to you with renal vein thrombosis. So any child on nephrotic syndrome and he's taking steroid presenting to you with severe bilateral flank pain, you have to suspect renal vein thrombosis. So the best investigation for this is Doppler ultrasonography. What happens in nephrotic syndrome? Some children develop acute complete venous occlusion, which is characterized clinically by sudden onset of, you see, when there is renal vein thrombosis, there will be sudden onset of macroscopic hematuria, flank pain, and tenderness. And in children with bilateral disease, you see acute renal failure. And Doppler ultrasonography shows an increase in kidney size and absence of blood flow in the renal vein. And the second option, if at all you have to choose, or if Doppler ultrasonography is not given for you as an option, then the second thing you can go is CT scan with contrast. Next is child with focal segmental glomerulosclerosis, nephrotic syndrome, no remission after 8 weeks. You have given 8 weeks of steroids, still there is no remission. What to give? oral steroids plus you have to add cyclophosphamide. In steroid dependent and frequently relapsed nephrotic syndrome treatment, cyclophosphamide and an alternate day. In frequently relapsed nephrotic syndrome, you consider cyclophosphamide and alternate day steroid. Suppose now this in steroid resistant, if it is steroid resistant nephrotic syndrome, you prefer cyclosporin or tacrolimus are recommended as initial therapy for children with steroid resistant nephrotic syndrome. Mycophenolate can maintain remission in children with steroid dependent or frequently relapsing nephrotic syndrome. If we see our case here, he is telling the child is focal segmental glomerulosclerosis nephrotic syndrome and no remission after 8 weeks of steroid means it is mostly going on with steroid resistant nephrotic syndrome. So our option here should be cyclosporin or tacrolimus. If it is steroid resistant, we'll choose cyclosporin and tacrolimus. Because this is recommended as initial therapy for children with steroid resistant nephrotic syndrome. Mycophenolate can maintain remission in children with steroid dependent or frequently relapsing nephrotic syndrome. Okay, just 1 minute. So let's remember, in steroid resistant nephrotic syndrome, we will prefer cyclosporin and tacrolimus as initial therapy. But once remission has occurred in cases of steroid dependent or frequently relapsing nephrotic syndrome, you can start mycophenolate in these cases to maintain the remission. If they are steroid dependent and frequently relapsed, you should know this. If the nephrotic syndrome is steroid dependent, then you will definitely consider oral steroids. And plus there is frequent relapsing. It is steroid dependent. Once you give, it is reducing, but again it is frequently relapsing. So you prefer to add one more drug, that is cyclophosphamide. In steroid dependent, along with the oral steroids, if it is frequently relapsing, you'll consider cyclophosphamide. If it is steroid resistant, then you'll consider cyclosporin and tacrolimus. Once there is remission in children with steroid dependent or frequently relapsing, you'll consider mycophenolate for maintaining the remission. Definitive treatment of renal failure is renal transplantation. So child with diarrhea, he has diarrhea and then he developed dehydration. And you see that in this child with diarrhea and dehydration, you see a flank mass and hematuria. Again, same. Flank mass, flank fullness, hematuria, usually suspect renal vein thrombosis. Here, additionally, the child is getting dehydrated due to diarrhea. So diarrhea with dehydration, then there is flank mass, hematuria, diagnosis is renal vein thrombosis. Diarrhea causes dehydration, which lead to renal vein thrombosis. Its signs are hematuria, flank pain, and oliguria. Treatment of congenital nephrotic syndrome. Treatment of congenital nephrotic syndrome is bilateral nephrectomy and
I'm assuming the PD means peritoneal dialysis.
I
Maybe.
think so, maybe. But sometimes in these children, they also give albumin every weekly or every 2 times a week. I think he's giving the final treatment here, bilateral nephrectomy with peritoneal dialysis. Next, case of 12 years old female with dark urine and abdominal pain. Increased blood pressure, temperature 39, urine analysis. Are proteins, there is 2 plus. RBCs more than 10. WBCs more than 10,000. The diagnosis here is acute glomerulonephritis. There is, what are the positive points here we see? Let's check. There is increased blood pressure, that means hypertension in this child. Along with that, there is dark urine and abdominal pain. And temperature is also very high, that is 39. Urine analysis, you see protein 2 plus. RBC is more than 10, WBC is more than 10. Diagnosis is acute glomerulonephritis. We'll go for the next question now. 6 years female. 6 years female and developed nocturnal enuresis. Next is 6 years old female, developed nocturnal enuresis. Was previously okay. Lower abdominal pain and urine analysis. WBC is more than 10. RBC is more than 10. That means there is hematuria. Protein plus 2. Blood pressure 110/73. Now the question is, what is the normal blood pressure for 6 years old female with this the formula? So
I think it's 2 times the years plus 80.
yeah,
Or is it 70?
70 is minimum. Means I will tell you, yeah, 70 plus 2, 70 plus 2 into 6, 6 twos, 2 into 6, that is 6 twos are 12. So anything below 82 is hypotension for her. This is 110, that means it is high. Let us calculate the higher limit now. Higher limit also for this age, higher limit is 90. The lower limit is 70 plus age into 2. Higher limit is 90 plus age into 2. 90 plus 6 into 2. What we got? 12. That means 100, 102. But this patient has 110. That means this is hypertension. That is how you check in the exam whether this child has hypertension or not. Most of the time they give BP to you, but they will not tell you that the BP is raised. You yourself have to calculate and check. This is how you calculate. For minimum blood pressure, anything lower than this value is hypotension. Anything more than this value is hypertension. So 90 plus age into 2 is maximum. 70 plus age into 2 is minimum BP. So this child has more than 102. That means this is hypertension. So the 6 years old developed nocturnal enuresis, lower abdominal pain, urine analysis, WBC stent, RBC stent, protein plus 2, blood pressure is raised, that is hypertension. So what might be the cause? The cause might be pyelonephritis. CBC is okay except for anemia, they have written. Other options are the glomerulonephritis, hemorrhagic cystitis, and appendicitis.
From this parameters, how do we differentiate glomerulonephritis and pyelonephritis?
Usually this you see hypertension and protein plus 2 in glomerulonephritis, right? Sorry, in glomerulonephritis, right? Do you see that in pyelonephritis? High blood pressure?
Yes, if you look at the case above, it's almost the same parameters. There's increased blood pressure. The only difference in glomerulonephritis is there's temperature, but the protein, the RBCs, the white cell count, and the blood pressure are all raised.
What is the only difference you said?
The temperature. But I'm assuming in pyelonephritis there might be temperature. So that's the only thing not from the first and the second case. So how do we differentiate the two?
السلام عليكم.
وعليكم السلام.
في البايلونيفرايتس I think the white blood cell cast, not white blood cell just. I means white blood cell here like bus cell. I am right or not?
I think so too, but they didn't say anything about casts. So.
Yes, cast indicate renal.
Yeah.
Yeah, it can be cast, yes, in pyelonephritis, right?
I'm not sure.
Okay. BP not that high to say glomerular. Why he's telling why pyelonephritis? He's giving the explanation here. Why in this case there is high BP, but he's telling not very high. BP is not high to say glomerulonephritis and no history of previous infection. Whenever to say glomerulonephritis, we should have some said that this child had sore throat or acute tonsillitis or acute follicular tonsillitis before 1 week. That is not given here in the history for you. So BP not high to very high to say glomerulonephritis, no history of previous infection, most of the scenario going with pyelonephritis. Abdominal pain is one of the pyelonephritis symptom. So here there is lower abdominal pain. Anemia can be with both. Since anemia can be with both, since there is hematuria can be due to other cause, we have to see the result of CBC. With hemorrhagic cystitis, RBC is more than 10. So the reason here why they are choosing pyelonephritis is they have not given that the child has 1 week before any like 1 week or 10 days before any history of sore throat or throat infection, which suggests glomerulonephritis. And also they expect the BP to be slightly higher than this in glomerulonephritis. Let's go to the next question. 7 years male with nocturnal enuresis, have no social problem, not complain anything a day. That means he's fine, but he has nocturnal enuresis. Good relationship with the family and at school. What is the diagnosis? That means looks like a benign case. The child has no social issues in the school or at the home, and he does not have any complaints as such. He's in good relationship with everyone and even at the school. So does this, it will be UTI. UTI, usually you will have fever or dysuria and many symptoms, not just nocturnal enuresis. Psychological issues, that means you should have problems in the school or at the home. That is not there. So this is just a decreased urinary bladder capacity. Two-month-old child with generalized edema since birth. Decreased albumin and increased cholesterol and triglycerides. What to do? That means this is 2 months old presenting with generalized edema since birth. I think this is congenital nephrotic syndrome. And we see decreased albumin, increased cholesterol and triglycerides in these cases. So the best option is bilateral nephrectomy and peritoneal dialysis in these cases. All the other can be an option if you have to treat only medically. But if you plan for any permanent solution, then you have to go for bilateral nephrectomy and peritoneal dialysis. Newborn insulin-dependent diabetes mellitus with polycythemia. Develop, again, there is renal mass, hematuria, thrombocytopenia, renal vein thrombosis. What is the investigation? So ultrasound is the
دوبلر بيعملوا التراساوند دوبلر.
Yeah, ultrasound is the investigation to check for renal vein thrombosis. Because the child here is presenting to you with polycythemia and there is a renal mass, hematuria, thrombocytopenia. If there is no option of ultrasound, then you will choose CT with contrast.
لو كانت في الدوبلكس كنا اخترناه يعني ولا شنو؟ ما فاهمه. السي تي بس كونتراست ولا دوبلكس ولا شنو الاجابه؟ شنو؟
Wait, best investigation for renal thrombosis is telling duplex. What is duplex? Doppler ultrasonography?
اتوقع دوبلر التراساوند.
Okay.
لانه انت في النهايه الالتراساوند العاديه ما بتوضح لك حاجه، انت بدك تشوف الثرومبوزس في الفين، صح؟ فاذا عايزه كونتراست وداير، فعشان كده الالتراساوند ما بتوضح.
No, it should be Doppler ultrasonography.
It's Doppler
should be
ultrasound.
Doppler. Not just ultrasound, Doppler ultrasound. Okay.
يس.
Okay, child
with contrast كمان كاتب 100.
Child presented to ER with hematuria, abdominal pain, vomiting, diarrhea 5 times per day. Low oral intake, low urine output. Investigations show blood pressure 130/90. Temperature 39. Urine analysis, high RBCs, high WBCs. How to diagnose? So again, hematuria, abdominal pain, vomiting, diarrhea 5 times per day, and poor oral intake. Definitely poor oral intake will cause low urine output. And there is hypertension here. And
اتوقع برضه بتعمل رينال كيس رينال فين ثرومبوز زي ما قال، لانه ديهايدريشنز ما قال لك يورين اوت، عشان كده الرينال سكان هي اللي اجابه كان.
Again, he's giving us the picture of renal vein thrombosis. there is so many points here for that. One is the hematuria, abdominal pain, and this BP, high blood pressure, and low urine output because low intake and also because of the thrombosis. Then high RBCs, high WBCs in the urine analysis. So if you suspect renal vein thrombosis, you will go for renal scan. If your suspicion of the answer is like acute glomerulonephritis or something, you will choose ASO titer and C3, C4. Let's read this.
Severe gastroenteritis lead to severe dehydrations, lead to decrease the renal perfusions, lead to renal vein thrombosis.
Yes, yes. So this is one of the reason they told vomiting and diarrhea also here. This is the clue also. Vomiting, diarrhea 5 times a day, that means dehydration. Dehydration will cause increased the blood becomes thick and more chance of thrombosis. This is one of the predisposing factor for renal vein thrombosis. Acute onset of renal vein thrombosis at any age causes pain in the lower back, sides of the abdomen, fever, bloody urine, decreased urine output, and sometimes kidney failure. Other symptoms include high blood pressure or pushing, sound heard by the physician when he or she places a stethoscope on the abdomen. This sound is the result of blood attempting to pass through the blocked vessel. That means when you put the stethoscope there, you hear a sound like shh. That means there is some block there. This sound is the result of blood attempting to pass through a blocked vessel. The doctor may also feel the enlarged kidney during physical exam, and some patients have no symptoms. So you can feel the enlarged kidney